This is part of a series I call the Making Evidence-Based Medicine Simple series, or MESS for short. In MESS Minis, I review an essential evidence-based medicine concept. In this MESS Mini, I review the interpretation of recursive partitioning decision trees. At the completion of this presentation, you'll be able to interpret a recursive partitioning decision tree to generate a 2x2 table in order to calculate the rule characteristics, quantify the benefits of the rule on resource utilization, and quantify the risk of the rule on missed patients with disease. So what is a clinical decision rule? A clinical decision rule is a group of predictors used to make clinical decisions. It may include elements of the history, physical examination, and basic laboratory tests. In essence, the parameters that make up the rule can be thought of as a diagnostic test. Examples of clinical decision rules include the Ottawa ankle rules, the Nexus cervical spine rules, and the PCAR and head trauma rules. Clinical decision rules assist or direct a clinician to a specific course of action. Clinical prediction rules appraise the likelihood of a future clinical event. These terms are frequently used interchangeably. The goals of a clinical decision rule are to correctly identify patients at high risk of the outcome, and to correctly identify patients at low risk of the outcome to reduce resource utilization in the low-risk patients. In general, a high sensitivity is prioritized over specificity in the derivation of a clinical decision rule. This is because missing a serious outcome is considered less desirable than reducing resource utilization. Essentially, we use clinical decision rules to allow us to stratify the patients into high and low risk categories. The rule characteristics, sensitivity, specificity, predictive values, and likelihood ratios help to assess how well the rule accomplishes risk stratification. There are 4 stages of development for a clinical decision rule. These are derivation, narrow validation, broad validation, and impact analysis. In this MESS Mini, we'll focus on stage 4, or the derivation of a clinical decision rule. The derivation is the identification of factors predictive of the outcome. See a separate MESS Mini on clinical decision rule stages of development and applicability for a more detailed explanation of these topics. For the derivation of a clinical decision rule, the investigators generate a list of potential predictors of the outcome of interest from the available evidence, including items from the medical history, physical examination, and basic laboratory tests. They examine a group of patients and determine each patient's status regarding the presence or absence of the clinical predictor and the outcome of interest. Statistical analysis reveals which predictors are most predictive of the outcome and which predictors can be omitted from the rule without loss of predictive power. Commonly used multivariable statistical techniques include logistic regression, recursive partitioning, and linear regression. Which type of regression to use is based on the type of dependent variable. Linear regression is used with a continuous dependent variable. Logistic regression or recursive partitioning are used with a nominal dependent variable. The example we review today is a nominal outcome variable and uses recursive partitioning. Before we can talk about the results of a clinical decision rule, we need to touch briefly on the concept of multivariable statistics. This slide illustrates a bivariate or bivariable analysis. We have 4 potential predictors of the outcome that are labeled as variables A, B, C, and D. Each independent or predictor variable is compared to the outcome variable separately to determine if a statistically significant association exists. In this example, there is a statistically significant association with variables A, B, and D with the outcome. There is not a statistically significant association between variable C and the outcome. A multivariable analysis compares the significant or nearly significant predictors from the bivariate analysis simultaneously the outcome variable to determine the independent effect of each variable while the other variables are held constant. In the prior slide, we had determined that variables A, B, and D were statistically significant in the bivariable analysis, so we include them in the multivariable analysis. We do not include variable C. Only variables A and D remained independent predictors of the outcome in this example. In this example, you are trying to derive a clinical decision rule for appendicitis. We've identified 4 potential predictors for appendicitis: right lower quadrant tenderness, vomiting, fever, and psoas sign. In the bivariable analysis, right lower quadrant tenderness, vomiting, and psoas sign are statistically significant predictors of appendicitis. Fever is not a statistically significant predictor of appendicitis. In the bivariable analysis, right lower quadrant tenderness, vomiting, and psoas sign are statistically significant predictors of appendicitis, so we have included them in the multivariable analysis. We do not include fever. In the multivariable analysis, right lower quadrant tenderness and psoas sign are statistically significant independent predictors of appendicitis. In the multivariable analysis, vomiting is not a statistically significant independent predictor of appendicitis. Inclusion of vomiting does not add to the prediction of appendicitis with right lower quadrant tenderness and psoas sign. Binary recursive partitioning is the most common type of multivariable analysis used in the derivation of clinical decision rules. The benefits of recursive partitioning when compared to logistic regression are that you can set criteria to prioritize a high sensitivity, which is one of the goals of deriving a clinical decision rule, while logistic regression prioritizes accuracy, and the output is in the form of a decision tree that is easier to interpret than logistic regression equations, and allows for easy calculation of the rule characteristics. This is an example of a decision tree using a hypothetical appendicitis clinical decision rule. In the recursive partitioning analysis, only right lower quadrant tenderness and psoas sign were identified as independent predictors of appendicitis. Right lower quadrant tenderness is the most predictive and becomes the first node in the decision tree. It is the predictor that is most successful at dividing the cohort of patients into those with and without appendicitis. Other predictors are added to the tree in order of most predictive to least predictive. This is a simplified example of recursive partitioning decision tree. Recursive partitioning creates multiple trees to choose from and edit. The first parent node contains a total of 1,000 patients, 200 of which have appendicitis. This is divided into two child nodes, yes and no, by the variable right lower quadrant tenderness. Nodes at the end of the branch are called terminal nodes. We will use the terminal nodes to determine what is considered a positive rule and a negative rule, and to create a 2x2 table to calculate the rule characteristics. The terminal nodes for which the answer to the question of the presence of the predictor variable is yes indicates a positive rule. These are patients at higher risk of the outcome. In this example, if the patient has right lower quadrant tenderness or psoas sign, they are at higher risk of appendicitis. There is a 30% risk of appendicitis, 180 out of 600 if there is right lower quadrant tenderness, and there is 19% risk of appendicitis, 19 of 100 if there is no right lower quadrant tenderness but there is the psoas sign. Notice that you can't determine the risk of appendicitis for a patient with both right lower quadrant tenderness and a psoas sign from the decision tree. You can only calculate the test characteristics for psoas sign only after patients with right lower quadrant tenderness are excluded. The terminal node with a value of no for all predictors indicates a negative rule. These are the patients at lower risk of the outcome. In this example, if the patient does not have right lower quadrant tenderness and does not have a positive psoas sign, they're at lower risk of appendicitis with a risk of 0.3%, 1 out of 300. We can use the data in the decision tree to complete a 2x2 table that will enable us to calculate the rule characteristics and the rule's potential impact on resource utilization. The outcome, appendicitis, is indicated as yes or no in the columns. The rows indicate the clinical decision rule status as positive, yes, or negative, no. A rule is positive if at least one of the predictors is present, and the rule is negative if all the predictors are absent. In our appendicitis example, the rule is positive if right lower quadrant tenderness or psoas sign are positive. The rule is negative if right lower quadrant tenderness and psoas sign are negative. From the parent node, we can see that there are 200 patients with appendicitis out of the 1,000 patients, for a prevalence of appendicitis of 20%, 200 divided by 1,000. If there are 200 patients with appendicitis of the 1,000, then there are 800 patients without appendicitis. 1,000 minus 200 equals 800. From the yes nodes, we can see that there are 700 patients, 600 plus 100 with a positive rule, and from the no node, we can see that there are 300 patients with a negative rule. From the yes nodes, we can see that 199 patients, 180 plus 19, with a positive rule had appendicitis, and from the no node, we can see that one patient with a negative rule had appendicitis. We've previously determined that 700 patients had a positive rule, and 199 of those patients had appendicitis. Therefore, 501 patients, 700 minus 199 with a positive rule, did not have appendicitis. We previously determined that 300 patients had a negative rule, and one of those patients had appendicitis. Therefore, 299 patients, 300 minus 1, with a negative rule, did not have appendicitis. We've now completed our 2x2 table. As a quick check, the columns and rows add up to the marginal totals that we identified at the beginning. These are the rule characteristics based on the 2x2 table that we just generated. I used the diagnostic test calculator from the Center of Evidence-Based Medicine website to calculate the 95% confidence intervals for each of the rule characteristics. We have determined that 20%, 200 out of 1,000 of the patients in the study had appendicitis. If the rule was positive, the risk of appendicitis was 28.4%, 199 divided by 700. This is the post-test probability of appendicitis if the rule was positive from the predictive value of a positive rule. If the rule was negative, the risk of appendicitis was 0.3%, 1 out of 300. This is the post-test probability of appendicitis if the rule were negative by calculating 1 minus the predictive value of a negative rule. There is a much larger change from pre-test to post-test probability if the rule is negative, from 20% to 0.3%, which is a 67-fold decrease, than if the rule is positive, from 20% to 28.4%, a 1.4-fold increase. We can also use the decision tree to determine the potential impact on resource utilization. This is the primary benefit of the rule. The patients who are rule negative are those that have potential to reduce resource utilization. In this example, 300 of the 1,000 patients, or 30%, would be considered low risk for appendicitis and could potentially not undergo further testing. And 700 patients, 600 plus 100, would be considered high risk and would undergo further testing. How much the rule reduces resource utilization depends on the baseline rate of utilization of the resource. If the initial CT scan rate was 90% and the CT rate using the rule is 70%, then the reduction in resource utilization will be 90% minus 70%, or 20%. The primary risk of using the rule is in missing patients with appendicitis. In this example, 0.1%, or 1 out of 1,000 patients with suspected appendicitis, would be missed by the rule. The benefits of using the rule, a reduction in resources, should be interpreted in the context of the risk of using the rule, and that is missed appendicitis. Recursive partitioning is used with dichotomous categorical outcomes, such as yes or no. The benefits of recursive partitioning when compared to logistic regression are that you can set criteria to prioritize a high sensitivity, which is one of the goals of deriving a clinical decision rule, and that the output is in the form of a decision tree that is easier to interpret than logistic regression equations. From a decision tree, you can generate a 2x2 table to calculate rule characteristics, quantify the benefits of the use of the rule on resource utilization, and quantify the risks of the rule on missed patients with disease. Related MES minis include clinical decision rule developmental stages and applicability, and diagnostic test or rule characteristics.